Evening, a hearty welcome to all the faculties and all the delegates for today's ISCCM ICU clinic. Uh, uh, Thanks to ISCCM National President, Secretary for Academic Events, and my heartfelt thanks to Dr. Ranveer Singh Tyagi sir, President-elect, for this ISCCM ICU clinic regularly having this academic meet for which are real cases and real learning for the IDCCM and DRNB students. So giving them the opportunity throughout the nation so that two students can present real cases, those which will come in their exam, and the examiners. Like today, we have Arindam sir and Dr. Panja sir, who are examiners of IDCCM and DRNB. They will be asking questions. So it will be a unique ICU learning experience for the students, and they will have the opportunity to face their examiners. So once again, I welcome Dr. Arindam sir, who is the Additional Director, Critical Care, Sri H.N. Reliance Foundation Hospital at Mumbai. He was the General Secretary of ISCCM from 2020 to 22. He was the Examination Controller of Indian College of Critical Care 2022 to 24. And at present, he is the Secretary, Indian College of Critical Care Medicine 24 to 26. And he has a lot of publications. He is the teacher, guide, examiner of IDCCM and DRNB students. So I welcome you, sir, for today's ISCCM ICU clinic. I also welcome Dr. Soren Panja sir, who is the head and senior consultant, Department of Critical Care Medicine and Internal Medicine, and he is the administrative lead, Critical Care Services, NH Foundation Eastern Region. He is also the teacher and guide examiner for IDCCM and DRNB students. So I welcome you, sir, for today's ISCCM ICU clinic. I welcome Dr. Ranveer Singh Tyagi sir, who is the President-elect and whose vision is the ICCM ICUs for the students. So I welcome you, Ranveer sir, for this academic session. I also welcome my colleague, Dr. Bhavani from Hyderabad, my colleague, Dr. Reshu from Guwahati, and I also welcome Dr. Venkat Kola and Dr. Bikram Gupta, who are guide for this ICCM ICU clinic. And I also welcome all the delegates who have joined for today's ICCM ICU clinic. So without further delaying, we'll start the session. The first case will be by Dr. Vibhuti Joshi, who is the DRNB second year student from Bhubaneswar. I welcome Dr. Vibhuti. And the second case will be by Dr. Manas, who is the IDCCM students from Guwahati. So I welcome you, Dr. Manas. So first case will be presented by Dr. Vibhuti for 20 minutes, followed by the second case by Dr. Manas for 20 minutes. Then there will be question answer session by both the examiners to both the students. And if any questions from the delegates in the chat box, that will also be discussed during the question answer session. And it will be by Dr. Bhavani and me will be taking up the questions for the examiners. So, at last, the vote of thanks by Dr. Bhavani. So, now I invite Dr. Vibhuti to start his case. Anything from the examiners, Arindam sir and Soren sir or Ranveer sir?
No, just you already welcome to all our esteemed examiner and the new role of coming Dr. Arindam Kar as a Vice Chancellor next year. He will take charge in 2026 and for 27. Along with this, my privilege to invite both of the esteemed faculty, both are good human being, good clinician, and good academicians. So they have all three quality. I want to give message to students for critical care. We need three things: academician, clinician, and a good human being. So
absolutely,
both examiner have all three quality. So please go ahead. Thank you.
So Dr. Vibhuti, you can share your slides.
Thank you, sir, for giving me the platform to present before the national faculties. A very good evening to all the panelists here. Myself, Dr. Bibhuti Padjoshi, second year DRNB trainee from Sam Ultimate Medicare, Bhubaneswar. Today I will be presenting a case on ACLF, which was there in our ICU few months back. Starting with our case, a 42-year-old male from Anugul, Odisha, presented with complaints of jaundice for 30 days, abdomen distension for 20 days, altered sensorium for 3 days. He was admitted 6 months back with similar complaints and diagnosed as chronic liver disease. He is a known alcoholic. History of presenting illness. He was apparently asymptomatic 30 days back to start with yellowish discoloration of eyes initially noticed by family members, followed by progression of yellowish discoloration to involve upper body, and he also noticed yellow discoloration of urine followed by abdomen distension for 20 days and altered sensorium for 3 days. And it is associated with high colored urine, anorexia, no history of black colored stools, no history of itching, no history of pain abdomen. He has history of hospital admission 6 months back with similar complaints. He is a known alcoholic. Coming to the past history, he has history of admission 6 months back with similar complaint of jaundice, abdomen distension and altered sensorium and diagnosed as chronic liver disease. He is a known alcoholic, no other addictions, no history of coronary artery disease, tuberculosis, or any major medical or surgical illness. Past medications, tablet ursodeoxycholic acid, tablet he is on thiamine, no history of any Ayurvedic medications, no transfusion history, he had no travel history. On admission, patient was irritable and opening eyes on command E3, V4, he was confused, V4 and M5, average built and nourished, height 150 centimeter, weight 58 kg. Vital parameters were temperature normal, pulse 68 beats per minute on right radial artery and of good volume, blood pressure 130 by 70 millimeters of mercury in right arm supine position, respiratory rate of 16 per minute. On general examination, icterus present, no pedal edema, no cyanosis, no clubbing, no lymphadenopathy, JVP not raised, no spider nevi and palmar erythema, no scratch marks. Coming to systemic examination and per abdomen, on inspection, umbilicus everted, no dilated veins, scar sinus or visible pulsations noted. On palpation, distended abdomen, no guarding and rigidity. On percussion, dullness noted and fluid thrill present. On auscultation, bowel sounds heard. On initial assessment and management, his airway was patent with good cough reflex. Breathing, bilateral air entry was there with respiratory rate of 16 per minute and saturation of 96% at room air. He was hemodynamically stable with a BP of 130 by 70 millimeters of mercury and heart rate of 68 beats per minute. On ultrasound abdomen and pelvis, it revealed coarse hepatic echo texture, moderate ascites and splenomegaly, and features of portal hypertension were noted. Echo screening was done and normal systolic functions noted with normal ejection fraction. Initial CT brain was done and it did not reveal any significant findings. Carried out with investigations, blood glucose, 12-lead ECG, arterial blood gases, liver function test, renal function test, complete blood count, coagulation parameters, PT-INR, chest X-ray, viral marker, IgM hepatitis A and E virus, tropical panels were sent, urine routine microscopy, and blood cultures. ABG, pH was 7.39, PCO2 36, PO2 78, lactates 1.6, bicarb 22. Urine pus cell 1.2 per high power field. Tropical panel reports were negative. Procalcitonin 0.14 nanogram per ml. Serum ferritin 1137 nanogram per ml. Viral markers hepatitis HIV, hepatitis C virus, and HBsAg surface antigen virus were non-reactive. Ascitic fluid showed total count of 200. Polychromasia 50%, polymorphonuclear cells, lymphocytes 50%, and serum albumin ascitic to albumin gradient was high. IgM hepatitis A virus was positive. Ultrasound which was done on day 1, abdomen, liver appears enlarged in size with coarse ecotexture 15 cm with features of portal hypertension. Hepatic veins and portal veins normal, spleen enlarged, moderate ascites noted in the ultrasound abdomen and pelvis. Then investigations carried out from day 1 to day 5 of ICU stay. We'll individually discuss day-wise when we'll discuss this in the ICU course of stay. Coming to my differential diagnosis of acute on chronic liver failure, decompensated chronic liver disease, viral hepatitis A, tropical fever. Then coming to day 1 ICU stay, he was on hepatic NKF grade 2 with GCS of E3V4M5. After ruling out sepsis by sending sepsis markers, medical gastroenterologist planned to start plasma exchange in view of hepatic NKF grade 2 and deranged liver functions. He was arranged with 12 unit fresh frozen plasma for plasma exchange. Protocols prior to start of plasma exchange followed and antibiotics started empirically, ceftriaxone and zone. Gut sterilization with lactulose and rifaximin also started. Prednisolone 40 mg OD started prior to plasma exchange. Serum ammonia was 132. Foley's and Ryle's tube inserted. Ryle's tube feeding of 200 mils second hourly started. Fast plex was completed and he was hemodynamically stable during the entire procedure. The day 1 HB reports are HB 7 gram per deciliter, TLC 6900 per cubic mm, platelets were 1.25 lakhs per cubic mm, coagulopathy INR 2.6, total bilirubin raised, it is around 14.5, and direct bilirubin 10.8 gram per deciliter. Transaminitis also noted, SGPT 1760 units per liter, SGOT 1650 units per liter, alkaline phosphatase 142 units per liter, protein 5.9 gram per deciliter, albumin was slightly on the lower side 2.6 gram per deciliter, creatinine 0.8 milligram per deciliter, sodium 131, potassium 4.3, and the viral markers we sent HIV, surface antigen and C and E were non-reactive, and hepatitis A virus IgM antibody is positive. ICU day 2. Liver function test and serum ammonia repeated. Improvement in liver functions noted. As we can see here, coagulopathy also improved. INR from 2.6 to 1.71. Platelet further decreased to 1.02 from 1.25. Total bilirubin decreased from 15 to 10.9 and 8.8 direct bilirubin. SGOTPT from 1500 1600 it decreased to 780 units per liter, and SGOT 650 units per liter. Alkaline phosphatase 156, albumin 2.8, creatinine 0.4, sodium 135, potassium 4.8. We can find significant decrease in transaminase and bilirubin and coagulopathy INR post first session of Plex. Also significant reduction in serum ammonia also seen to 56 from 132, and there is also improvement in altered sensorium, and GCS improved to 15 from 13 previously on day 1. Antibiotic zone and ceftriaxone and doxycycline continued. Upper GI endoscopy was done. Small esophageal varices with non-bleeders noted. Gut sterilization with lactulose and rifaximin continued. He was hemodynamically stable. RT feeding continued 200 ml second hourly. Therapeutic and diagnostic paracentesis was done with around 2.5 liters removed. Human albumin 20% started. Tablet prednisolone 40 mg continued. Coming to the day 3 of ICU stay, here second plague session started on day 3. He tolerated it well, hemodynamically stable, altered sensorium further improved, Rice tube and Foley's were removed, anti-hepatic encephalopathy measures continued, human albumin continued for 3 days. On day 3, we can see that INR come down to 1.4, bilirubin, total bilirubin to 8.8, direct bilirubin 6.4, SGPT further come down to 450, SGOT further come down to 350, alkaline phosphatase 148, albumin improved to increase to 3.1, creatinine 0.6, sodium 134, potassium 4.5. Then coming to ICU stay day 5, day 6. Gradually 3 sessions of Plex plasma exchange, each on alternate day completed. 3 sessions Plex day 1, day 3 and day 5. 3 sessions of plasma exchange was done. There is dramatic improvement in altered sensorium and liver function tests seen. Measures for anti-hepatic encephalopathy measures continued. Ascitic cultures and blood cultures were sterile. Antibiotics were stopped. And from now, workup for liver transplantation started. Here we can see post 3 session of Plex, there is improvement in platelet, improvement in INR to 1.26, total bilirubin coming down significantly to 1.9, SGPT coming down significantly to almost normal value 66, SGOT coming down to 48, alkaline phosphatase 117, albumin improved to 3.2 after 3 human albumin transfused, creatinine 0.7, sodium 136, potassium 4.2. He was shifted to ward after day 5 and 3 Plex sessions were completed. He tolerated 3 sessions of Plex well. Significant improvement in encephalopathy and liver function tests noted. He was discharged with home medications and advised for follow-up after 7 days. He was given the option for liver transplantation and further management at higher centers. So my final diagnosis is acute on chronic liver disease and etiology viral hepatitis A in chronic liver disease. Thank you.
Thank you, Dr. Bibhuti, for presenting
Yes.
the case. Now, I request Dr. Manas to present the second case. We'll take up questions for both the cases at the end. I request all the delegates, if they have any questions on this topic, to put up in the chat box so that we can take up the questions with the examiners and discuss after the cases
There are
are
already
presented.
a few questions there on the chat box, Dr. Anand. So we can save it for later.
Good evening, sir. Good evening.
You have to, Manas, you have to share your slide.
Yes, ma'am. I'm trying.
I think Dr. Vibhuti, you have to stop sharing.
Ma'am, I already stopped, madam.
No,
Okay.
it's
Stop.
still there. Yes. Manas, can you?
Yes, ma'am.
Okay. Start sharing then. Okay.
Very good evening to all the panelists here. I'll present my case on ACLF. My case is a 37-year-old male, married, belongs to a lower socioeconomic class, working as a sweeper in a private organization for the last 12 years. He's been chronic ethanolic since last 15 years, present mostly taking country liquor almost on a daily basis, around 180 ml. And his last intake was 5 days back. He was recently diagnosed at CLD 6 months back, was on irregular medical management. There was no other past medical or surgical history, no known allergic or transfusion history. In family history, he had a family history of essential hypertension of both parents. 6 months back, he had presented outside with symptoms of decreased appetite, mild swelling of both lower limbs. There was no history of black stool, altered mentation, or yellowish discoloration of the body at that time. USG was advised, which showed grade 3 fatty liver with liver parenchymal changes with moderate splenomegaly and minimal ascites. There was also a note of 5 mm non-obstructive left renal calculi and was diagnosed as CLD, mostly ethanol-related, child class A, left renal calculi. He was advised for absolute alcohol abstinence, started on ursodeoxycholic acid and low-dose diuretics, advised for upper GI endoscopy and follow-up. However, the patient did not comply to the advice, though he continued oral medications for 1 month. This time, the patient presented to us with chief complaints of nausea and vomiting, swelling of both lower limbs, yellowish discoloration of skin and eyes, fever on and off for the last 1 month, and recent history of altered mentation for the last 2 days. There was no history of black stool. The bowel habits were normal. Urine was high colored and decreased in amount. There was no history of pain abdomen. There was no recent travel history, cough, cold, burning micturition, chills, and rigor. On CNS examination, he was conscious and obeying commands, but mildly confused. His pupils were bilaterally reacting to light. In vitals, he was icteric. There was pitting edema positive in bilateral lower limbs. His BP was 100/60, heart rate around 85, normal in volume, regular. His SpO2 was 100% on repair, and respiratory, he was a mildly tachypneic, respiratory rate of 24. His chest, on auscultation, there were bilateral vesicular breath sounds heard, no added sounds. And on cardiological CVS examination, there was S1 and S2 heard with no murmurs. On abdominal palpitation, it was mildly distended, soft, non-tender. Bowel sounds heard. Sorry, ma'am. Bowel sounds heard. Liver lower border palpable 2 centimeter below the ribs, and the spleen was equally palpable. Bladder emptied with Foley's catheterization, and high colored urine was seen. On neurological examination, there was no neurological deficit. Power of 5/5 on all 4 limbs. The deep tendon reflexes were normally elicited. There was a flapping tremor positive. The patient was admitted and sent to ICU for further monitoring and management after sending the basic blood investigations and a CT brain to rule out any structural cause. The patient was the patient was received in ICU with the probable diagnosis of decompensated CLD, mostly ethanol related, sepsis with AKI query. He was in encephalopathy, which could be either septic, metabolic, or withdrawal, or even encephalitis. Was started on carbapenem, injection meropenem, and other liver supportive medications from emergency, and after sending blood and urine cultures and routine blood investigations. The CT brain revealed no parenchymal lesions or bleed. The chest skygram was normal without any evidence of consolidation or infective etiology. The ABG done at the emergency showed normal anion gap metabolic acidosis with lactates mildly elevated of 2.4. The lab results that we received, it showed a hemoglobin of 7.7. Total count was raised 17,000. Platelet count of 1,45,000. Urea and creatine were raised. Urea was 87, creatinine 3.2. And rest of the electrolytes were more or less normal. LFT was highly deranged. Bilirubin was 26.8, direct being 23 and indirect 3. SGOT, SGPT was raised. GGT was
Anant, can you check the voice is not coming?
yes. Am I audible, sir? Am I audible, sir?
Yeah, right now you are audible.
Yes. The LFT was highly deranged, bilirubin being 26, direct 23, and indirect 3. SGOT, SGPT was raised, SGOT being 193 and PT being 84. And there was a coagulation defect in the form of PT being 61 and INR 5.75 and albumin to 2.5. Amylase and lipases were normal. The viral markers were non-reactive. CRP was raised 57, and fever profile for topical infections were negative. The patient was hemodynamically stable, maintaining on room air. A bedside focus was done, which revealed a good LV function with no pericardial effusion or RV dysfunction. The IVC was collapsible. In IVC, collapsibility index was around 30%. Lungs were bilateral A profile with few scattered B lines at the bases, and there was free fluid in the abdomen. Following Foley's catheterization in the accidental emergency, the patient had an urine output of around 100 ml in the last 3 hours, and the patient was given fluid bolus of 500 ml and a maintenance fluid of around 100 ml, which intermittent monitoring of fluid status, and was advised to repeat a ABG after 2 hours. Gastroenterology opinion was taken and planned for upper GI endoscopy. Nephrology opinion was also taken. So what do we have here? There is definite liver dysfunction in the form of hepatitis. As you can see, there is increased bilirubin, enzymes, PTINR, and hypoalbuminemia. The next thing we have, that is the encephalopathy, which could be either because of it could be hepatic encephalopathy, could be alcohol withdrawal, or could be septic or metabolic NKF or encephalitis. In the background of CLD, which is ethanol related, because we can say that by presence of portal hypertension, splenomegaly and on USG and palpable spleen, and ascites, which could be either because of hypoalbuminemia or portal hypertension. There is presence of renal dysfunction, which could be in the form of AKI, which could be either sepsis related. As you can see, there is decreased urine output, raised urea creatinine, and metabolic acidosis, or could be hypovolemic or because of dehydration. There is also a possibility of HRS in the background of CLD. The infection markers were high, so it gives us that there is also some component of infection or sepsis might be there, as there is history of fever, organ dysfunction, lactates, and increased sepsis markers. There is presence of anemia, which could be either because of any chronic disease or occult blood loss, or could be nutritional. Now, after that, if we look at the scores, we went for the Cliff C ACLF score, and we did the scoring. And similarly, we look at the hepatic encephalic grading by the West Haven criteria for mental status grading, and the MedRACE discriminant factors and MBLD scores. Looking at that, in our patient, the CLIF-C ACLF score was 52, which predicted a 30-day mortality of 33%. MedRACE discriminant factor was 246, which indicated to a poor prognosis, and MBLD score was 49, which indicated 71% mortality in 90 days. Medication, patient was already started on meropenem from emergency, which we continued. Was started on vitamin K, ursodeoxycholic acid, rifaximin, proton pump inhibitors, thiamine, albumin, and lactulose laxatives. The next day, the upper GI endoscopy was done, which revealed a grade 2 esophageal varices with endoscopic variceal ligation was done. Orally liquid diet was advised. Non-selective beta blockers, Cardivas was added, and branch-chain amino acids were added in the form of supplements. Advised to repeat ultrasound and a Doppler splenoparietal axis with fibroscan. Nephrology consultation was taken and planned. They have planned for conservative management, and patient was still oliguric with the urea rising to 99 and creatinine to 4. Bedside ultrasound, USG guided diagnostic ascitic tapping was done, and fluid was sent for investigation. The patient was hemodynamically stable, drowsy but arousable, oliguric for the last 12 hours. This was the ultrasound, and it showed esophageal varices grade 2 with severe portohepatic gastritis. In day 2, in view of worsening RFD, the urea has jumped up to 110 and creatinine 4.6. Even after 48 hours of albumin, injection terlipressin was added. The ascitic fluid report, which is suggestive of transudative fluid and SAX ratio more than 1.1 with cell count of 300, mostly polymorphonuclear cells, and where the cultures was awaited. It suggested towards possibly a cause of spontaneous bacterial peritonitis. The patient was hemodynamically stable, drowsy, but response to verbal stimulus and was confused. The investigation that was repeated on day 2 revealed that total count has increased further to 18,480. Urea jumped to 110, creatinine 4.6, bilirubin 28, direct being 26 and indirect 2.4. Albumin was 2.3, and serum ammonia has jumped to 146. So here we have a case of ACLF in the background of CLD, which could be because of ethanol related with portal hypertension, with grade 2 esophageal varices, with ascites, with precipitating factor being infection, probably spontaneous bacterial peritonitis or alcoholic hepatitis, with worsening encephalopathy and coagulation profile and renal parameters. The medical management was continued. With the high risk of 28 days mortality and likelihood of a diagnosis of ACLF, the patient is a potential candidate for liver transplant. The patient attendants were counseled and need for liver transplant and poor prognosis liver transplant and a poor prognosis without that had been explained. Belonging to the poor socioeconomic status and possibility of liver transplant was rejected by the patient attendant and was planned to continue with conservative management with organ support, including invasive mechanical ventilation and RRT if needed. Patient was planned for a repeat ultrasound and with Doppler splenoparietal axis and fibroscan on that day. At around 2 p.m., the patient had a GTCS with vomiting. Loading dose of 1 gram levetiracetam and midazolam 3 gram given, and the patient was electively intubated with rapid sequence intubation for airway protection. Infusion mannitol 100 ml bolus was given, and it showed anisocoria. Bedside optic nursery diameter was checked and it was more than 6.5, suggestive of raised ICP. Infusion 3% NaCl 50 ml bolus and infusion at 15 ml per hour started, and the patient was sent for NCCT brain. The CT brain shows as such. There was a large hemorrhagic lesion with perifocal edema with left cerebellum and vermis with brainstem compression and transtentorial herniation. The hemorrhagic lesion in bilateral thalamus and intraventricular and subarachnoid extension of the hemorrhage with mild to moderate subtentorial hydrocephalus with mild periventricular CSF seepage. Urgent neurosurgery consultation taken and requisition and cross-matching of 2 unit PRBC, 5 units FFP, and 10 units cryoprecipitate given. The pupils were sewed, fixed, and dilated. Neurosurgeon reviewed the case and prognosticated the attendant regarding the possible poor prognosis. However, option of decompressive craniotomy with high-risk consent was given to the attendant. The patient attendant did not give consent for the same. Medical management continued for raised ICP in the form of hypertonic saline, ventilator settings, analgesia and sedation, and muscle paralysis. By 9 p.m. that evening, the patient had an autonomic instability with bradycardia initially, which was treated with injection of atropine boluses, and which ultimately led to hypotension and asystole. Resuscitation attempted with high quality CPR, but the patient could not be revived after 40 minutes of CPR, and the patient was declared dead at around 10:15 p.m. So this was my case. We could not save the patient. Thank you, sir.
Manas, I think you stop sharing the slides, then it will be all visible.
Thank you. A lot of questions had been asked also in the
Chat box.
QA and chat box, both ways. I think, guys, you should, Q&A, you should ask in the question answer. It would be easier. Many a times people have the option to answer you back live on that day. We have noted down, so I will request my senior Dr. Panja to start the proceedings, and I will also chip in. Sir, if you just to give you a backdrop, Dr. Panja and myself, in fact, Dr. Panja was senior to me, and he was one of the pioneers to, as well as the part where we started the liver transplant program in the country itself. So I think Anand has really sort of selected a person who has got huge experience, as well as we learned over the period of time that how things changed. So please, sir, you start asking, then I will come also join.
Okay. Sorry. I think both the cases discussed. Thank you, Dr. Manos and Dr. Manos and Dr. Saurabh, na?
Vibhuti, Dr. Vibhuti.
Yeah. So I think both the cases you presented, that is an excellent presentation, I must say, at your level. And about the diagnosis, the approach, I must appreciate that you have done the EA. So there are certain questions there in the exam, or sometimes we think in terms of the EA. So because you know this is the case where there is some pre-existing CLD, chronic liver disease, or sometimes cirrhosis. So some questions may barely come to the mind that what is the definition of ACLF that you should know. So because there are students also, and how is it different from a chronic liver disease or cirrhosis is a decompensated liver failure. Because we have to have clarity in our definition. One is ACLF definition versus a decompensation of the chronic liver failure, or we commonly call it as decompensation of the cirrhosis of liver or chronic liver disease. So can anyone start discussion? Then we will go to the other questions, and then there are many questions in the chat box that we will also open up.
Now, I have written down certain questions. I think you have asked that this one, right? Acute and non-acute. So who is going
not
to
acute.
answer?
Basically, there is one is a ACLF. Basically, this is acute decompensation. How is it defined from a decompensated chronic liver disease? Because it is important, because ACLF there is a scope that you need to immediately pick up the case and then aggressive treatment. And decompensated chronic liver disease is not that acute, so you will get time. And ACLF carries one message that you should also be prepared that this patient may require liver transplant. So that is why it is important. And that's why I have put this question. And they, in examination, they will obviously ask you sometimes this question. Am I right, Arindam?
Yes. Who is going to answer this?
For
I
for
think
ACLF, there are
uh,
various guidelines are there, European and American. As per American guidelines, there is acute deterioration in the clinical condition of the patient associated with coagulopathy INR more than 1.5 and deranged liver function bilirubin greater than 5 milligram per deciliter with one extra hepatic, more than one or one extra hepatic organ involvement should be there. This is as per the American guidelines. This is acute and chronic liver failure. And decompensated liver failure, in a pre-existing chronic liver disease, there is involvement of refractory ascites, hepatic encephalopathy, organ involvement. This can lead to decompensated liver failure.
so
I think what you should, all the students should read. You can stick to anyone. EASL is a nice one, where they have divided that the progression of cirrhosis into two: non-acute decompensation and acute decompensation. And what they have also done is that they have divided acute decompensation into 6 clinical phenotypes. In that, one is a no ACLF, which have 3 different A. One is your stable decompensation, unstable decompensation, and pre-ACLF. And you have 3 grades of ACLF itself. Mostly, this is in terms of prediction of the mortality, as well as also allocation of your resources, urgency of your intervention. So these are your more or less A. But there are always a lot of overlaps. And in actually clinical decision makings, right, it does not make much of a difference to the clinician. We are here to save lives itself, but mostly decision making, urgency, and also the need of liver transplantation itself. Okay, who presented the first case? I have certain questions.
Sir, myself, sir, Vibhuti.
Vibhuti, Vibhuti, your diagnosis was mostly this is on the viral hepatitis, right?
Yes, sir. Yes, sir.
Which was the precipitant. We all know that there are precipitants which destabilizes a cirrhotic patient itself. Did you ever consider anything to treat the viral hepatitis itself? Do you have any medication than others, or you thought of something?
So for viral hepatitis is a standard treatment we followed, sir. And we planned for, sir, since liver failure and hepatic NKF grade 2 was there. So we planned for, with our gastroenterologist, we planned for plasma exchange, sir. Otherwise, sir, standard treatment
I will
protocol.
come to that. But do you have any options for any specific treatment of viral hepatitis?
Viral
No, Jadhav, there
hepatitis,
is no role of vaccination as of now. In decompensated day, you don't vaccinate a person on that part. Okay, so that's an A. So in examination, you would be asked, tell me very quickly what are the precipitants that can lead to an acute or chronic liver failure.
Arindam, just one
viral
question
hepatitis.
to Vibhuti.
Just a minute, Dr. Panja wants to ask something.
Because this patient continued to take that alcohol, consume the alcohol even in spite of your 6 months before patient was admitted, and when patient was readmitted, that time also there was chronic alcohol was going on. So here in your hepatitis A is one of the precipitating. I think alcohol should also be kept in the A. Okay.
Yes,
just
sir.
one comment.
Actually, I kept the question for alcohol for the next candidate because that was a clear alcohol-related decompensation.
No, actually, both the
many of
patients
the
were
times,
alcoholic.
I completely agree with you, sir. Many of the times, we have multiple factors as precipitants, right? So be it your A, and in fact, there could be concomitant. Someone consuming alcohol comes with a bleeding as well as SBP. So you have to tackle everything put together on that part.
Sir, viral hepatitis AE, reactivation of hepatitis V virus, sepsis, spontaneous bacterial peritonitis, upper GI bleed, drug-induced liver injury, and like, sir, autoimmune hepatitis, Budd-Chiari.
Layer of autoimmune hepatitis, absolutely.
Layer of autoimmune, Budd-Chiari syndrome, ischemic hepatitis.
Ischemic and viral hepatitis are lesser common because we have now much better but most of the times either it is a decompensation due to bleeding, infection, particularly in terms of whether you have bacterial peritonitis or
SBP.
spontaneous empyema or bacteremia itself,
Alcohol,
drug induced,
sir.
which is an NA, and the rare causes are hepatitis and ischemic hepatitis and all others. Fair enough. I think you covered more or less. We have a lot of questions on the indications of therapeutic plasma exchange, right? So, what is a classical indication in this scenario in ACLF?
In
And
ACA,
yes, please.
sir, in ACLF, sir, here, our patient is having, sir, liver
In
dealing.
general, I'm asking you in general.
Sir, basically to take time, to buy time for this is basically a method for bridging for liver transplant, sir. To buy time.
Dr. Panja, you want to add anything? Because there are a lot of
I think
questions on.
in that actually before going to that definitely you are right that it is a bridge therapy, but there are some areas. Actually, not that all candidates will be a candidate for the liver transplant. Some candidate may go into the liver transplant depending on the grading. So you go to that grading, and so depending on that grading, if severe, then immediately patient should be transferred to the center with liver transplant. Because in our country specific, if you transfer all the patient to the liver transplant, so then the transplant unit will also not be covered. Okay. So that will be very difficult to tackle. So it is the relatively severe cases on the day one. If you can calculate whatever grading you are doing, so you can send. And second thing about the plaques and because some candidates, they may be a candidate when as in your case also, patient improved little bit. So some may respond to your plaques or other supportive therapy. But if the patient is with severe grade 3 or part of the grade 2 severity, they should be transferred to the transplant center. Okay. So that is here. And about, as Arindam told, that plaques is itself is a chapter in chronic liver disease, because the European versus it is more of an Asian country specific guidelines. They endorse as well as recommend it. But the Europeans, the Westerns, they are not very proactive on that plaques therapy. And most of the studies that has been published, that is in our Asian countries. Okay. So that is one thing important. And before that, I am asking one question. Sometimes in examination may be asked, what is the basic pathophysiology that you are thinking about giving plaques in ACLF?
Sir, basic pathophysiology is to remove the toxins which is not metabolized by liver. Basically, sir, centrifugal method we do, sir, basically to remove inflammatory and the toxic from the plasma, sir.
Okay, you are right actually, because it is one hyperinflammatory state. Sometimes some toxins as well as cytokines they are here. So you are right. So that is the basically okay. And also it may correct some of the coagulopathy and also sometimes ammonia and other toxic metabolites.
Ammonia.
Okay. Arindam, you please carry on.
Now the other thing is that how do you do that with a standard dialysis machine, or do other options also?
Sir, we have a different plex machine, sir, that gastroenterologist and the technicians they used to operate, sir.
You are not aware of it, because your plasmapheresis can also be done on your apheresis machine, which is operated by the blood bank itself.
Yeah.
And in fact, in that the blood flow is much lesser, and you can actually use peripheral access too, and hemodynamic stability is much restored on those way. So that is a good improvement that had happened on the plasmapheresis itself, right? What are the complications of plasmapheresis itself in plaques?
Sir, it can cause hypotension, sir. Chances of bloodstream infections, contamination infections, hypotension.
Any other?
Sir, bleeding because of coagulopathy and all.
Now you said, Dr. Panja said the bleeding can be more coagulopathy, can be more bettered with the plasmapheresis. You are giving new plasma, right? You are exchanging it itself, right? So you have to understand that there are a lot of electrolyte imbalances. You are giving a lot of volume itself, right? Plasma. What does plasma does if you infuse a lot of plasma? What is the
The trali taco, all these can happen.
so
Sir.
that has to be also considered because your plasma has the maximum ability or the infliction or potential to cause trali itself, right? That is sort of a. You said that you have had whatever you present, right? We are smart cookies. We had been taking exams for years. So whatever you say, always remember in the examination, that would be picked up by the examiner. You are giving cues to the examiner itself. You said that you have assessed that the plex worked. How do you assess the effectivity of plex?
Effectivity of plex, sir, symptomatic improvement like bilirubin.
You said that
coming
the
down.
patient improved after plex. I'm
Yes,
asking you, how did you, hey, is it only symptomatic or you have some objective assessment too?
Sir, lab values we did, sir, like liver enzymes with bilirubin and serum ammonia we sent, sir. And clinically, altered sensorium, all these are improved, sir. Like hepatic NKF improved, sir.
I would have been happy with some more objective answers itself. So either your serum markers, your electrolytes, your at times immunoglobulin levels, then objective improvement in the bilirubin values, your liver enzymes, then improvement in the neurological status. So please give objective answers, right? And your answers has to be very confidently given to that part. Okay, I think who was the other guy? Manos. Manos, what are the role of steroids in alcoholic hepatitis, particularly when you have come up with a ACLF situation?
Yes, sir. The steroids can be given, but the MELD score that is advised for steroids is from 25 to 30. If beyond that, it has got more negative outcome. If you give steroids,
Why negative?
sir, sepsis, the
Infection is the major risk.
Yes, sir.
So what is the current guidelines, both ESL and American guidelines
So steroids.
for steroids in acute alcohol-related decompensation or alcohol-related precipitation of ACLF?
So MELD score of less than 30, sir.
Are they recommending it or they are saying it that you should be very cautious and case to case? So your answer should be case to case. Every individual case has to be assessed. The risk of infection has to be taken into account, right? Conclusively, we should be definite of there is no active infection in place itself. And then we should consider the benefit outweighing the risk itself. So that's how you confidently answered in exams itself, right? 1, 2, 3, 4 points. And so you send the message that I'm considering steroid itself. I know there is ambiguity in the guidelines itself, but practically it works at certain period, at certain circumstances itself. And I am aware of the complications, so I'm taking cautionary steps about it, right? So that's how you answer, because in this very critical situations, right, we do not have very black and white answers, right? We know therapeutic plasma exchange, we do the maximum. I think our center, Medanta, Gangaram, the Apollo Chennai, we do the maximum. And our hepatologist has the biggest series in the country itself on the therapeutic plasma exchange, which we do for bridging to the transplantation itself. When we have a donor ready, the workup is going, some issues are there where it's getting delayed, so we do that. Therapeutic plasma exchange and this ESLD, this has got the best outcomes in 3-month transplant-free survival. So these are the two best. The ESLD is not available right now. This is the layer of hepatocytes. We're trying to get that where it's sort of bioartificial liver itself, right? But you have to give answers like that, and you have to say that you got a good control over the situation itself. Okay. The
Arindam,
other
actually,
question. Yes, sir.
in exam, actually, regarding steroid, they will ask dose of value you have mentioned, and also along with the dose, how many days you will consider, okay? Because that also varies. And during the process, suppose when you have to prematurely stop it. So these are the actual scenarios. Suppose you are giving steroids, suddenly something wrong happened, or patient is not responding. So when you will take a judgment, then you have to stop it also. And obviously, as Arindam told, that there are contraindications to the steroid because it is not that always good. Sometimes patient may not respond, and also there are certain contraindications, particularly for the sick patient. So these contraindications, can you mention some of the contraindications of steroid in spite of the discriminative index more than 32?
Sir, if there is active bleed, sir, presence of
Active
sepsis,
bleed.
presence
Active
of
bleed means specifically GI bleeding.
GI bleed,
Okay.
sir. Yes, sir. GI bleed, sir. Then, sir, presence of active infection.
Absolutely. Then, so sometimes patient might have hepatorenal syndrome. So ideally in hepatorenal syndrome, you should not give. And also if there is other complications, organ failure like your pancreatitis or your, so ideally should not be given. Okay, and patient is a very poor diabetic control. Those who are diabetic with bad metabolic control is also relatively here because that time it rather than benefit, it is also risk is also very high. That's why people used to stay away from that here. And usually, as I told, how many days you will give steroid if you are giving? Usually 4 weeks people used to give, but prematurely you can stop if there is no, actually objectively patient is not responding to your steroid therapy. Okay. So these questions may be asked actually because steroid is on. Acha. Arindam, please
role
continue.
of albumin. Both
Role
of
of
you,
albumin.
I think both of you used albumin, right?
Yes, sir.
So role of albumin here in ACLF very specifically.
Sir, in spontaneous bacterial peritonitis, then large volume paracentesis, and in hepatorenal syndrome.
So in to prevent what we call paracentesis induced circulatory dysfunction, LVP, and there is certain A that what is the dose for each, how many in large volume paracentesis, what is the dose?
Sir, up to we can go up to, sir, if we are if more than 5 liters we are going, sir, then we can go up to, sir, 30 grams, sir.
You read about that if after 3 to 5 liters, for every liter you give how much, right? There is a specific dosage or we normally do not follow, right? We normally tend to give, it depends on a name. And the other is on your reversal of HRS, combination of albumin, terlipressin, oblique, NORAD, even midodrine albumin combinations are also. These are the certain recommended indications of albumin. But what was the albumin given in both the cases? What role you were looking into? Manas, you can also answer.
Yes, sir. So in my case, the albumin was given for treatment of HRS, sir. The liver RFT was deranged, so it could be AKI or HRS. So we started with the albumin therapy. If in 48 hours there is no response, then it's most probably could be because of AKI, sir. Even after adding terlipressin also, sir.
Okay. Also, can both of you mention that there was a component of hepatic encephalopathy itself, right? So what is the pathophysiology behind hepatic encephalopathy in ACLF? Is it different with fulminant hepatic failure, or both have almost a similar A? Is it due to cerebral edema or circulating neurotoxins like mercaptans and others? What do you think? What is your opinion?
Sir, in acute liver failure, sir, it is cerebral edema and raised ICP. That is caused by, sir, ammonia. That is from gut, it going to the portal circulation, going to liver, and from liver, it cannot be metabolized, so it is going to the brain, sir, through systemic circulation. And basically, ammonia, sir, crossing blood-brain barrier, then crossing astrocytes, then swelling of cells caused by intracellular change in the intracellular environment. And there is
So
also
do
a
you think that
mechanism Trojan
hypertonic
horse.
saline would help in those situations?
Sir, in acute liver failure, sir, cerebral edema with raised ICP, hypertonic saline, sir, will help, sir.
And how much sodium do you keep as a target?
And we target of from 145 to 155 milliequivalent, up to 160 also we can go, sir.
Okay. And what about ACLF? Is there any difference? Will both hypertonic saline and mannitol may work?
Yes, sir. Yes, sir.
Yes, Vibhuti and A. Manas,
Yes, sir.
any one
Yes,
of
sir.
you can.
Yes, sir. It will work, sir.
How would it work in terms of you have to understand the pathophysiology in that way, right? Dr. Panja, you want to comment?
Yeah. No, I was thinking there were some questions actually that I just saw in the chat box.
I
So
am
you
trying to
finish
cover
it.
those also.
Uh,
A lot of
And then
steroids
one
and all
question,
others.
and I think thalidomide, they have some mention that any role of that one or not. And another good question is basically centrifugal plex versus membrane-based plex. Which one is yeah?
Now we covered that earlier. That
Many questions
apheresis
have been
technique,
covered, sir.
centrifugal.
Yes.
Okay.
Sir, just sorry to interfere. We will go through the case-based discussion. I think when you are Arindam sir is going on, so we'll go through the case-based discussion. I think with that, most of the questions are being covered. And I'm looking out. If any questions are missed, in the end, we will answer those questions, sir. Thank you.
Okay. So regarding the case, I think they may discuss that later on also about the hepatorenal syndrome, and they may come in regarding this case actually. And also what are the common infections that is in this type of cases you may face, they will ask. And what should be the empirical antibiotics, as well as sometimes what are the prevalence of infection in our country or the unit specific.
Couple of things I think as there is now shortage of time. Both of these people were in active drinking, right? So what could have been your anticipation, the problem that you should have anticipated, or maybe you have anticipated, not mentioned? Manas, your patient was actively drinking.
Yes, sir.
Right? So what are the problems that can happen on that part? One, obviously, it's an alcoholic hepatitis C precipitation and others.
Yes, sir.
Now he has stopped drinking, right?
Yes, sir. So he presented with encephalopathy, so which could be a withdrawal also, sir.
So there's an active withdrawal with delirium tremens and
Yes,
all
sir.
sort of things. So how do you prevent that, or how do you treat that even in that case?
Benzodiazepines, sir. Lorazepam.
That will aggravate your hepatic encephalopathy. And then that will also confuse you with whether this is the progression of the disease process, ACLF, or this is a effect of the benzodiazepine, right? In fact, which benzodiazepine you can think of?
Lorazepam, sir.
Lorazepam in A. Very. Vibhuti, you want to answer?
Sir, haloperidol and chlordiazepoxide, if a patient is in HE grade 1, grade 2, not intubated, in that case, we can also give sir dexamate, sir. Because dexamate will reduce the load of
Metribuzin is
benzodiazepines.
the new kid on the block for your delirium tremens, DT or alcohol withdrawal.
It will decrease the load of benzodiazepines.
With your supplementation of glucose, thiamine, and all others, which sort of a standard care on that part. Okay, there was a variceal bleeding in the second case, right? Some bleeding itself. Manos, did you mention bleeding?
There was a grade 2 varix on ultrasonography. Sorry, endoscopy, sir. It was
but not bleeding, active bleeding.
No
wasn't
bleeding,
there.
sir. No bleeding, sir.
Okay, so any role of tips at times if there has been active bleeding?
Yes, sir.
In ACLF.
Yes, sir. TIPS is advisable, sir, if there is active bleeding in ACLF, sir.
It's just presence of varices or if there is an uncontrolled bleeding?
Sorry, uncontrolled bleeding, sir.
Okay, so that is also nene. You also mentioned about non-selective beta blockers, right?
Yes,
So
sir.
what is the recommendation right at this moment, and what is our concern by continuing with continuation of non-selective beta blockers?
Sir, non-selective beta blockers are usually added for the portal hypertension, sir, to decrease the portal hypertension.
Your patient has grade 2 varices which can bleed
Yes,
any
sir.
point of time. So
Yes,
you are
sir.
tempted to continue with the non-selective beta blockers, right? But what
Yes,
should
sir.
be your concern then if you are still continuing to use?
Respect to hypotension,
Hemodynamic instability.
instabilities.
So the guidelines are not sure. Again, case to case basis. It's a controversial recommendation that they have given it upon the physicians to decide on individual case basis. None of you have, both of you presented well, but none of you have touched upon the nutritional intervention itself, right? So how to assess sarcopenia, frailty, because almost every patient of CLD, be it decompensated or ACLF, has got sarcopenia and frail patient, right? So assessment of sarcopenia, frailty, which has got a very, very strong association with the mortality, has to be there. You should mention the nutrition when nutritional status and on that part. So I think one of you mentioned on the branch chain amino acid. How does it work, and what are the contraindications of BCAA?
So I did mention.
Then you should answer. Okay, Vibhuti, you want to take this?
Sir, actually, branch chain amino acid, not much role, sir. Not also recommended, sir. Means.
Are you sure on that? Then tell me what are the active nutritional interventions that you do in a ACLF. A lot of questions are coming, either a glutathione or a L-ornithine, arginine,
Lola.
and all others, or a soluble fiber, which is a hit subject nowadays, right? Restoring the gut microbiome itself, right? Reducing the overproduction of the pathogenic bacteria. So please have a very clear idea on all these factors. Nutrition is no more a supportive, it is a therapeutic intervention, and particularly in ACLF, in all others. Obviously, Abhishek rightly said that when you are having an AKI higher creatinine, it has to be stopped. So there are certain cutoff. A lot of hepatologists say not above 1.5, 2. So we always discuss with them with the two continuation on all this. More or less, I have asked most of the questions. I think Dr. Panja, it would if wants to ask any more.
No,
Panja sir.
I think more or less we have covered the topic in general, whatever questions, probable questions usually asked in the exam. And there may be some other question, may not be directly related, indirectly related questions may be asked, okay, in this type of cases separately. And depending on your case, what are the complications and I think more or less nutrition part, also branch chain amino acid, not that it is there is no role, there is certain roles, there are pros and cons, but still people used to believe that branch chain amino acid in certain cases may be helpful, okay, particularly if the patient is in encephalopathy.
So
Okay.
there is a question in the question answer session that gut sterilization with lactulose and rifaximin, is it the correct way to say?
Gut sterilization, I think Dr. Manos or Dr. Ye, if you want to answer, please answer, then we can give some comments.
Sir, gut sterilization with lactulose and rifaximin, it has a role in CLD patients. In acute liver failure, no role, sir. In CLD patients, we can use that,
But
sir.
now, what about the ACLF? You are dealing with the ACLF.
Still in ACLF also, sir, we can use, sir, lactulose and rifampicin.
So in ACLF, the more or less answer is it might have a role. Okay, because here you have gone through the ammonia is one of the key molecule. Sometimes it may be related to your metabolic septic encephalopathy or whatever encephalopathy is there. So in this case, ACLF answer is okay. We should use this gut sterilization. About Dr. Arindam was about the microbiota. We are really not sure in this case whether the microbiota, because there are pros and cons also, because it may not only benefit, sometimes it may cause invite harm also. So I think better to stay away from the microbiota till date, whatever evidence in my knowledge. Okay, so it is better here. Okay, Risu, I think that is.
There are, sir, two more questions I think which we have not answered. Rest all the questions we have answered. One is role of NAC in viral hepatitis, and is there role of tenofovir as in viral hepatitis? Those are the two questions left unanswered.
I think Dr. Manas or Dr. you can answer. Then if anything, we can also try to.
Tenofovir in acute, whereas an ACLF, very difficult. Your margin time is a. In fact, we have used in selective immunoglobulin as a passive sort of support or sort of a. There are available your IgM immunoglobulin, anti-hepatitis A immunoglobulin we have used. And
actually, if there is acute viral hepatitis B flare, that you have to then you may consider. Okay,
now one of the cases were acute viral hepatitis A induced ACLF.
So basically, Risu is
in those
asking
situations you can consider on that.
Hepatitis B you may consider, okay, because if the hepatitis B reactivation is also one of the cause for your ACLF, so then you can consider. And about the NAC, there is a bit controversial, but ACLF and even without any direct paracetamol, non-paracetamol also, some people used to give, okay. About
Sorenda, NAC is indicated in most of the time for the fulminant hepatic failure. Both paracetamol and non-paracetamol. But in acute decompensation of chronic liver failure, ACLF, I don't think there is any recommendation of NAC in any way on that part. Unless it is a very clear case of DILI itself, drug-induced liver injury. In those cases, they do consider, the hepatologists do consider, but I will get back on this, that the clear dictate of that. But otherwise, non-drug induced precipitation of ACLF, no role of NAC, paracetamol related fulminant hepatic failure, yes. But in other non-paracetamol, a lot of hepatologists are actually using as a non-specific improvement.
Okay, any other question? I think then we can wind up the session.
So we have almost answered all the questions from the chat box and the question answer.
Okay. So then, thank you all. And
Sir, I think it was a great discussion, sir. And hello.
Hello, Anand, only one thing I have repeatedly seen in the year, how they can get the certificate. Okay, so please answer that, how can they can get the certificate, those who are attended. So I think there was 3-4 times I have seen in the screen it is coming. Okay.
Sir, I will discuss this with the ICCM and get back to you, sir. And
now,
they'll get
what
the mail.
Not me, but there are attendees. Okay.
I mean, Sorenda certificate लेके क्या करेंगे?
नहीं, sir. The participants, no.
मेरा तो एक ही सर्टिफिकेट आने बाद में वो तो चाहिए भाई, अभी वो नहीं चाहिए, ठीक है?
Regarding the delegates, yes, sir.
एक सर्टिफिकेट जब चाहिए तो पता. चलो ठीक है, thank you.
Now,
I think
tell me, Anand,
yeah,
what is the process for each participation? They are getting a certification.
Sir, we need to discuss this with Dr. Ranveer. What is the exact process for that? And we'll get back to them. I think they may receive it through the mail.
Then what would they do with it? Hello, boss, whosoever has put this question, the certificate, what will you do with it? I'm intrigued. Is the best time is that you take the knowledge, but more importantly, this is, I think, more oriented towards the exam going people, right? Particularly the fellowships, DM, DRNB, and others. So I think the mindset of the examiners, the questions those can be asked, what to read, where to read. Maybe also we can come up with in subsequent lectures or the case presentations. I might also request people, because you are all very privy to a lot of information itself. You should also put up one slide for further readings or references, so that people get to know, that helps each other and on that part. So these are the things are more important, I think. We would definitely evolve with this, and this is a very important day. In 1 year, you have 50 weeks, couple of weeks we will miss. So Anand, if you are coordinating with Dr. Tyagi itself, try to cover up with the 50 major cases. Those are normally being given in the exams itself. So that would...
Exactly, sir. This is as per the schedule. We are covering what are the cases being given to DRNB and IDCCM students. We are targeting those topics and elaborate discussion with the real examiners, who will be the examiners actually in these IDCCM and DRNB exams. So this is a good platform initiated by Dr. Ranveer, and this will give them a real scenario, case-based scenario that they will be facing in their final exam. So I would encourage more and more students to join and actively participate, so that that may help them in their final exam. Anything from Dr. Bhavani?
Yeah, nothing.
Wind up?
Yeah. Hi. Yeah, I think we had a wonderful discussion. In fact, long discussion on one of the important topic. So I would like to extend my heartfelt gratitude to all those who have contributed for today's ICU clinic. I would like to thank especially our examiners, Dr. Arindamkar, Dr. Sauran Panja, and also our mentor for today's clinic, Dr. Dr. Reshu Gupta, and my colleague, Dr. Anand Mishra, Dr. Ranveer Tyagi, and also the students who have, taken up the case studies, who have presented it very nicely, Dr. Bibhuti and Dr. Manas. And also, but not least, the participants and the ISCCM, for contributing to this ICU clinic, which is useful to many of the students nationwide. Thank you, everyone, and we will close this session.
Thank you, Arindam sir. Thank you, Panja sir.
Thank
My exam and my IDCC exam.
Thank you.
Thank you, sir. Thank you so much.
Thank you, sir.
Okay. Good.
Thank you, Dr. Reshu, and thank you, Dr. Bhavani.
Thank
Good
you.
night. Good night, all.
Good night. Good night.
Good night.